Let us now study the various clinical presentations caused due to the lesions to the brainstem. As we know, brainstem houses various ascending and descending tracts, cranial nerve nuclei, precerebellar nuclei, and reticular formation, which includes even vital centers like respiratory center and the cardiovascular centers. So lesion to the brainstem may involve all these structures at once, or it may involve only some of these structures. So some of the lesions which have a vascular cause may have clear-cut presentation because they involve a definite set of structures resulting in a well-defined syndrome. But other lesions due to trauma or tumor, they may have variable presentation depending upon which structures are involved in that particular patient. So when we work up a neurological case, based upon the clinical presentation, we can identify which structures are involved and we get a clue as to the most likely site of lesion. So in this video, let us first study some of the general features involving lesions to the brainstem, and then we go on to study the lesions of medulla oblongata. So brainstem lesions may present with motor presentations, cranial nerve nuclear presentations, sensory presentations, or with some ocular presentations. Coming to the motor presentations, the corticospinal fibers will descend from the contralateral cerebral cortex till it reaches the lower end of the medulla oblongata, where the fibers finally cross to the side where they are intended to go and control the muscles. So if there is lesion to the corticospinal fibers in the midbrain or in the pons or in the upper medulla, we will get contralateral hemiparesis because the fibers which are descending from the right cerebral cortex will be descending on the right side in midbrain, pons and upper medulla, but these fibers are actually meant to control the muscles of the left side. So lesion to the right-sided corticospinal tract fibers in the brainstem will result in left-sided hemiparesis. Similarly, the corticonuclear fibers, they have predominantly contralateral control. However, those which are meant to be reaching the motor cranial nerve nuclei, they will be having bilateral controls. This we have already elaborated in case of facial nerve nucleus. The corticopontine fibers again descend from the contralateral cerebral cortex and cross over in case of pons to form the middle cerebellar peduncle of the opposite side. Now coming to various cranial nerve nuclei, we know that third and fourth cranial nerve nuclei are located in the midbrain. Middle four cranial nerve nuclei are located in the pons, that is cranial nerve nuclei for the trigeminal, abducens, facial and the vestibulocochlear. And the last four cranial nerve nuclei are located in the medulla, that is glossopharyngeal, vagus, accessory and the hypoglossal. So when we identify that a particular cranial nerve is involved or a particular cranial nerve nucleus is involved, we know that most likely the lesion will be at that particular level of brainstem. Now coming to the combination of corticospinal tract fibers and some of the cranial nerve nuclei, we get what is called as crossed paralysis. Now here, whenever there is lesion to the cranial nerve nucleus, that will result in ipsilateral presentation. That is, if let us say for example facial nerve nucleus of the right side is involved, then that patient will present with right-sided facial paralysis. But when this is combined with corticospinal tract fibers on the right side in pons, then what we will get is a combination wherein a patient has right-sided facial paralysis with left-sided hemiparesis. So one side cranial nerve nucleus involvement, opposite side body muscles involvement. That is what we call as crossed paralysis or alternating paralysis. This can happen at any level of brainstem. In case of midbrain, it usually affects the third cranial nerve, that is ipsilateral oculomotor paralysis with contralateral hemiparesis. In case of pons, it may involve either the sixth cranial nerve or the seventh cranial nerve, that is abducens nucleus or the facial nerve nucleus. In case of medulla oblongata, it usually is a combination of hypoglossal nerve nucleus and the contralateral hemiparesis. So these are typically known as crossed paralysis or alternating paralysis, that is ipsilateral motor cranial nerve nuclei involvement and contralateral corticospinal involvement features. Now coming to the sensory involvement, we know that medial lemniscus fibers cross in the lower part of the medulla, that is closed medulla. The spinal lemniscus fibers will have already crossed in the spinal cord before they are sent to the brainstem. Trigeminal lemniscus, which carries pain and temperature sensation from the face, now those fibers will be crossing at the level of pons. In case of medulla, these fibers will be relaying in the spinal nucleus of the trigeminal of the same side. So we get an interesting combination here. If there is lesion at the level of midbrain, or even if you have the lesion at the level of pons, the patient will present with contralateral hemi-anesthesia. That is, the patient will have loss of vibration and proprioception sensation as well as loss of pain and temperature sensation on the opposite half of the body. That is, right-sided lesion will result in loss of sensation on the left side, both in the region of body and limbs as well as in the region of face. But when there is lesion at the level of medulla, there is loss of position sense or the proprioception sense and the vibration sense in the contralateral half of the body. There is loss of pain and temperature sensation in the opposite half of the body, but loss of pain and temperature sensation on the face is on the ipsilateral side, because there it affects the spinal nucleus of the trigeminal. So this will give us a clue as to one more way in which we can get the clue as to where is the likely site of lesion. Then there are a set of structures scattered throughout the brainstem. Whenever these structures are affected, the patient will present with some of the ocular presentation. Obviously, the presentation varies depending upon which structure is involved. At this point of time, we are only going to list the structures which will result in ocular presentations. So in case of midbrain, it includes the vertical gaze center, nucleus of the oculomotor nerve and the trochlear nerve, pretectal nucleus and the superior colliculus. In case of pons, we have abducens nucleus and the pontine paramedian reticular formation, which is the horizontal gaze center. At the pontomedullary junction, we have the vestibular nucleus, and within the medulla oblongata, we have perihypoglossal nuclei, which are located around the hypoglossal nucleus in the lower level. Plus, we have some fiber bundles, that is medial longitudinal fasciculus, which will be involved in the conjugate eye movements, dorsal longitudinal fasciculus, which is carrying the descending autonomous fibers. So involvement of this fiber bundle will result in Horner's syndrome. And then we also have the inferior cerebellar peduncle, which will be carrying fibers from the medulla oblongata to the cerebellum, involvement of which will result in oscillatory movements of the eyes called as nystagmus. So with this set of features which we have studied so far, we have roughly an idea as to what to expect in case there is a brainstem lesion at various levels. We will go into the details. First, let us begin with lesions of the medulla oblongata. Let us begin with this case. We had done this case in one of the earlier videos, but let us start it afresh. A 55-year-old lady presents with a history of slurring of speech, otherwise known as dysarthria, difficulty in swallowing, otherwise known as dysphagia, hoarseness of voice, otherwise known as dysphonia, and rotatory vertigo. She also complained of difficulty in walking and maintaining balance. So that means there is something to do with the cerebellar structures involvement. On examination, it was observed that she had loss of pain and temperature sensation on the right half of her face and left half of her body. So here we have dissociative anesthesia, that is one half of the face and the opposite half of the body have the loss of pain and temperature. This in itself should give us a clue that the lesion is most likely in the medulla oblongata. Her right eye revealed pupillary constriction and mild ptosis. So what is this clinical condition known as? What is this condition most likely due to? And explain the basis for the clinical presentation. So this condition is known as lateral medullary syndrome or Wallenberg syndrome, also known as crossed sensory loss or alternating hemi-anesthesia. This is caused due to the involvement of posterior inferior cerebellar artery. In this particular case, because of the list of symptoms which we have read earlier, this patient has got involvement of right-sided posterior inferior cerebellar artery, causing the set of symptoms. The posterior inferior cerebellar artery, otherwise called as pica. Okay. So let us look into the set of symptoms she came up with: slurring of speech or dysarthria, difficulty in swallowing or dysphagia, hoarseness of voice or dysphonia. Now this is because of the involvement of nucleus ambiguus. She also presented with rotatory vertigo, chakkar aa raha hai. Now that is because of the involvement of vestibular nucleus. Then she had difficulty in walking and balance. It's because of the involvement of inferior cerebellar peduncle, which will be carrying all the fiber bundles from the spinal cord to that is spinocerebellar tracts to the cerebellum. And then she presented with loss of pain and temperature on the right half of the face. Now that is because of the involvement of right-sided spinal tract and nucleus of the trigeminal, and left half of the body. That is because of the right-sided spinal lemniscus, which is carrying the pain and temperature sensation from the left half of the body. She also presented with right eye showing meiosis and ptosis. Now these are features of Horner syndrome. That is because of the involvement of dorsal longitudinal fasciculus, which will be having the descending autonomic fibers. So when we see the patient presenting, now in this case I have actually listed all the features which will be telling us what are the structures which will be involved, but quite often the patient may not have involvement of all the structures. She may come with combination of 1 or 2 or 3 features only. We will still have to work up as to the most likely site of lesion and therefore the most likely cause. So this is the lateral medullary syndrome. We mentioned about Horner syndrome because of the involvement of descending autonomic fibers. Now the sympathetic fibers which are descending through this brainstem, when they are involved, we get a set of symptoms. That is what we put together and call it as Horner syndrome. The symptoms include meiosis or constricted pupils, because you know that pupillary constriction is caused by parasympathetic fibers. So when the sympathetic fibers are cut, the parasympathetic fibers will have unopposed action. So the pupil goes into continuous meiosis or continuous constriction. Then there is a component that is ptosis or drooping of the eyelids. Now this drooping of the eyelids is because of the involvement of Miller's muscle, which is the smooth muscle along with the levator palpebrae superioris. Now that smooth muscle component is supplied by sympathetic nerves. So when that muscle is involved, there will be ptosis or drooping. This ptosis, however, is a mild ptosis. Then there is enophthalmos, or the eyes will be sunken. That is not an immediate effect. It will happen over a period of time. That's because the orbit is packed with fat or adipose tissue. When the sympathetic innervation is lost, over a period of time, this amount of fat tissue will be lost. Therefore, the eyeball will be sunken, resulting in enophthalmos. Please understand, this is not an immediate effect of the lesion. It will be over a period of time. Then there is anhidrosis, because the sweat glands are the only glands supplied by sympathetic innervation. So when the sympathetic fibers are injured, then there will be absence of sweating and absence of ciliospinal reflex. That is, on the same side, any pain to the skin will result in pupillary constriction. Now that will be lost in this case. So pinching on the, not pupillary constriction, the pupillary dilatation. So pinching on the back of the neck should result in widening of the eye or pupillary dilatation. Now that reflex will be lost because of the involvement of sympathetic fibers. So this combination of meiosis, ptosis, enophthalmos, anhidrosis and absence of ciliospinal reflex is what we call as Horner's syndrome. Then there is a condition called as Ondine's curse. This is again an interesting story behind it. There's a mythological story which says that Ondine was a nymph. She suspected her husband to be unfaithful to her. So she cursed him that if he goes to sleep, he stops breathing. So as long as he keeps awake, he can voluntarily control his breathing. The minute he goes to sleep, he cannot voluntarily control his breathing. Therefore, his breathing stops, otherwise called as apnea, and he would die. So that was a mythological story. Based upon that mythological story, this condition is named as Ondine's curse. However, the patients suffering from this particular condition have nothing to do with the curse per se. So these are the people who are suffering from severe sleep apnea. That is, they are unable to initiate breathing during sleep, which when it becomes severe, it may end up in death. And Ondine's curse is often associated with bilateral lower lateral medullary ischemia. So when there is lack of blood supply to the lower lateral end, which involves these respiratory centers, that may have the sleep apnea. It may also be because of some congenital condition, wherein we call it as congenital central hypoventilation syndrome. Now this is often because of mutation of FOX2B gene, and rarely it can also be iatrogenic, wherein post general anesthesia, patient wakes up, talks to people, or he at least responds to stimulus, but he again becomes unconscious and hypoventilated. That is because the anesthetic which is absorbed by the adipose tissue will be released much later. That is, there is a delayed release of these anesthetic drugs from the adipose tissue that will result in secondary wave of unconsciousness, where the patient becomes hypoventilated and he may die. So these are the causes for Ondine's curse, but in this particular video we are talking about it because it is caused due to bilateral lower lateral medullary ischemia. Now coming to the second case, a 60-year-old lady presents with weakness of muscles in both her upper and lower limbs of the right side, that is right-sided hemiparesis. On examination, the doctor observed that she had loss of sensation of discriminative touch and vibration to the right half of her body. That is, you can identify which is the fiber bundle which is involved here. And the tongue was deviated to the left when asked to protrude. So what is this clinical condition known as? What is the condition most likely due to, and explain the basis for the clinical presentation. So this condition is known as medial medullary syndrome or Dejerine syndrome. It's also known as hypoglossal alternating hemiplegia. You notice that there was left-sided hypoglossal nerve involvement and right-sided hemiplegia. So there's a crossed paralysis or alternating paralysis. So this condition is caused because of the involvement of anterior spinal artery. In this particular case, it is the left-sided anterior spinal artery. So what are the syndromes, or what are the symptoms, and what are the structures involved because of that? The patient presented with weakness of the right-sided limbs. Now that was because of the involvement of left-sided pyramids, contralateral control. Patient presented with loss of sensation of discriminative touch and vibration on the right side. That's because of the involvement of left-sided medial lemniscus. And patient had deviation of tongue to the left side. That is because of the involvement of left-sided hypoglossal nucleus or nerve. Now all these structures, that is pyramids, medial lemnisci, and the hypoglossal nucleus and the nerve, will all be supplied by branches from the anterior spinal artery, that is paramedian branches from the anterior spinal artery. Now when these structures are involved due to anterior spinal artery involvement, this particular syndrome is called as medial medullary syndrome or Dejerine syndrome. Now apart from lateral and medial medullary syndrome, we have another set of syndromes here in medulla. We have Avilis syndrome, which includes nucleus ambiguus and lateral spinothalamic tract. So the patient will always have soft palate and vocal cord paralysis, aphonia or dysphonia, and dysarthria. And because of lateral spinothalamic tract involvement, the patient will also have contralateral hypostasia, which includes the pain and temperature sensation will be lost. In addition to this, the patient may have involvement of those structures which were involved in medial medullary syndrome, that is pyramids or medial lemnisci or the hypoglossal nucleus, or the patient may have involvement of sympathetic fibers or even the spinal accessory nucleus, wherein the patient may show sternocleidomastoid muscle atrophy. So any combination will result in Avilis syndrome, but patients suffering from Avilis syndrome will always have involvement of nucleus ambiguus and lateral spinothalamic tract. Then there is Babinski-Nagios syndrome. Now here the patient will have all the features of lateral medullary syndrome plus involvement of corticospinal tract fibers. So when we have lateral medullary syndrome features with contralateral hemiparesis, that is what we call as Babinski-Nagier syndrome. There is a condition called as Opalski syndrome or submedullary syndrome. Here again there is a lateral medullary syndrome features plus there is ipsilateral corticospinal tract involvement. That is, if left-sided pica is involved, the patient will also have left-sided hemiparesis. That is because the lesion will be affecting much lower level of the medulla. So that is involvement of the corticospinal tract fibers after the decussation. So he will have the ipsilateral hemiplegia. There is a condition called as Reinhold syndrome or otherwise known as hemimedullary syndrome. Now this is equivalent to our Brown-Séquard syndrome of the spinal cord. Half the medulla is involved here. Now that is because of the involvement of vertebral artery. Now in this case, the patient will be presenting with symptoms of both medial medullary syndrome as well as lateral medullary syndrome. Now the way to differentiate this from the Babinski-Nagier is, in case of Babinski-Nagier syndrome, the 12th cranial nerve will be spared. But here even the 12th cranial nerve will be involved. Then there are few syndromes which have combination of nucleus ambiguous and corticospinal tract fibers. Only if these two are involved, it becomes Schmidt syndrome. So dysphagia, dysphonia with contralateral hemiplegia. If the same structures are involved along with descending autonomic fibers, that is patient coming with Horner syndrome features also, that is the Cheston-Chenies syndrome. Again, nucleus ambiguous corticospinal fibers with hypoglossal nerve involvement, that's the Jackson syndrome. Please don't be alarmed. Nobody is expecting you to memorize all these features, but we want you to understand what will be the likely feature the patient will present with when a particular structure is involved. That has to be understood on the basis of your anatomy knowledge. You can always come back and refer to the video whenever you come across an interesting syndrome in case of your neurology posting and identify what is the condition which the patient is suffering from. So this can be referred back to, but you must know in your mind as to what clinical feature has resulted from the involvement of which structure anatomically. Thank you very much. Hope you enjoyed this video. Visit the site for other neuroanatomy videos.